Hey guys, this is Dr. Charity Stanley, and today we're talking about adrenal disorders. The adrenal gland is a very interesting gland. It's actually located on top of the kidney. AD in Greek means on top of, and renal means kidney. It also can be called, it makes adrenaline, also can be called epinephrine. EPI means on top of in Latin, and neph, N-E-P-H, is it means kidney in Latin. So the adrenal glands are so important. They actually have two names. They make an adrenaline and they also make epinephrine. So there's some other hormones that are actually made within the adrenal glands as well. So on the surface, the adrenal glands appear to only be one organ, but it is actually two different separate organs. The adrenal gland is the part that sits on top of the kidney, and it makes epinephrine or adrenaline, like we just spoke about. But it also can make chemicals to help protect the body, like cortisol, or it's very much like a cortisone type product. These steroids help to protect the body from too much exposure to epinephrine. This would be the equivalent of you driving to class and not using your brake pedal. So if you drive using only your gas, you're only go, 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 go all the time, and you don't have anything to protect your engine from going that fast and going consistently, then what ends up happening is you crash, your car breaks, you break down. And so, with having epinephrine being produced, it's also important that we have some kind of steroid that helps to mediate the damage on the engine. And so, with that, that is the cortisol that is made. So, the adrenal glands make a couple of different things. The first thing they make is corticoids, which can be one of two different subtypes. Glucocorticoids is chiefly cortisol. So, if we're having to replace cortisol through medicine, then we would actually use the medication hydrocortisone. And so that is made through the metabolism of proteins and fats, and it has anti-inflammatory activity. So what happens is cortisol is what is helping the body to respond to the epinephrine and keeping the body from hurting itself too badly. It's kind of like a regulator on an engine to keep the car or the vehicle from going too fast and damaging itself. So that is cortisol. So cortisol is greatly involved in the metabolism of carbohydrates. When you're stressed, you want to eat. And what do you want to eat? It's not going to be carrot sticks. So it's going to be breads and pastries and donuts. And the cortisol pretty much turns down the inflammation within the body, and it slows the immune system down. So cortisol stimulates gluconeogenesis. So this is where the body is making additional glucose, and it likes to pack it on. In time periods of stress, people tend to pack on pounds in the central truncal area. And so with those additional pounds, it causes additional weight shifts and other issues. Now, another hormone is actually made by the adrenal cortex as well. This is a mineral corticoid. This is called aldosterone. Aldosterone, if it is messed up, is called Conn syndrome, CONN syndrome. Aldosterone decides how much salt you're keeping. And by deciding how much salt you're keeping, it stands to regulate the water balance, fluid balance within the body. And it does that through aldosterone. Other sex hormones, like androgens and estrogens, are also influence the release of glucocorticoids or mineral corticoids. So, if the adrenal gland is not working appropriately, we're going to have issues with both adrenaline and cortisol. So, big things that we need to ask about is we need to find out what the patient's activity level is, find out if they're having any kind of GI symptoms, or if they've been exposed to any type of radiation. The endocrine glands like to absorb radiation at a higher level than do other parts of the body. So it's important to find out if there's been any exposure like that. The severity of the symptoms is going to be related to how much, how low the hormone is, how high the hormone is. And you'll be doing multiple lab testings, CAT scans, and MRIs to be able to visualize what's happening within the patient's body. So, big things you have to focus on when the adrenal gland is not working as well, you're not making enough cortisol. You need to promote a fluid balance because cortisol helps to promote that. Monitor for dehydration and prevent hypoglycemia because remember, we talked about one of the functions of cortisol is gluconeogenesis. Without the hormone for cortisol, we cannot just replace the glucose and liberate it from our fat stores in the body. Hyperaldosteronism. So, aldosterone controls salt. The amount of aldosterone is directly related to the amount of salt that your kidneys hold on to. So, what happens if you have high aldosterone? This is Conn syndrome. With Conn syndrome, you're going to be holding on to every bit of salt that you can hold on to. And what ends up happening is by holding on to the salt, you're also holding on to the water. So you need to assess your patient for fluid volume overload, listen for breath sounds, crackles, etc. Now, with having too much salt on board, hypernatremia elevates blood pressure. So remember, one of the things that we do to treat blood pressure is go on a low sodium diet, 2 grams of sodium per day, and also referred to as the DASH diet. And it can also cause hypokalemia because sodium and potassium work opposite each other. One of the most common treatments for having too much aldosterone, hyperaldosteronism, is surgery, and that's where they'll go in and they'll remove one or both of the adrenal glands. So if you're wanting to avoid surgery in this situation, and use spirulactone. Spirulactone is a potassium that the patient would lose, would cause problems. So, with the adrenal disorders, if the adrenal system is not working, you're not making enough cortisol, you're not making steroids, then that is Addison's disease. Okay. The adrenal gland hypofunction is Addison's disease. So, there's a really popular president, John F. Kennedy, actually had Addison's disease. And so there's several effects. One of the things that happens with Addison's is your skin bronzes. And so you look like you have a tan all the time when you actually don't. What that does, it's caused due to the lack of cortisol. Now, if my adrenal glands are overworking and making too much cortisol, then that's called Cushing's syndrome. And differentiating these two is where we're going next. Cushing's syndrome. Now, there's two different things. There's Cushing's disease and there's Cushing's syndrome. Cushing's disease is caused by some kind of tumor growth on the adrenal gland that's causing too much cortisol to be made. Cushing's syndrome is when a patient is taking too many steroids, prednisone, and Cushing's syndrome is caused by drugs that increase the number of steroids in the body. So, risk factors for Cushing's disease: Most commonly hits females in the reproductive years between 20 and 40 years old. And there's several different ways that there's something organically wrong with the adrenal gland that's causing this. This isn't just a secondary drug exposure. That is Cushing's syndrome. But increased cortisol can be caused by adrenal hyperplasia, adrenocorticocarcinoma, problems with the adrenocorticotrophic hormone in the pituitary gland that causes the secretion of it, and different lung cancers and GI problems, and problems with the pancreas can also affect it. So risk factors for Cushing syndrome, remember, this is going to be overuse of medications that cause an increase in steroids, cortisol in the body, cortisones that you're taking. So this is going to be using glucocorticoids to treat organ transplantation. So you're trying to decrease the immune system activity with the organ transplant. After chemotherapy, you're trying to reduce the body's immune system towards it. Autoimmune diseases, asthma, allergies, and chronic fibrosis. So fibrosis is often in the lungs, and it's when somebody has worked in a position like putting in um, insulation in houses and spraying it. If those fibers get into the lungs, then it causes problems. And the skin, or the lung tissue, not the skin, tries to heal over it and make it all better. And that creates additional issues. So, things you would expect to find with this would be weakness in your patient, fatigue, having problems sleeping, back and joint disorders, decreased libido, and they're going to be very, very irritable and very, very depressed. Or they can go from angry to depressed or angry to sad, but it happens quickly and is often surprising to the patient and the patient's families. Physical assessment findings, this is going to be where you're having uh, decreased immune function, and you're going to have thin, very thin, fragile skin and Cushing's. Bruising and petechia. Remember, we talked about bruising means that it's a big area. Petechia is going to be fragile capillary type bursts. Hypertension, and this is due to the effect of cortisol on the aldosterone production. Weight gain due to increased aldosterone and increased fluid retention. And with a person having adrenal issues, they're not going to be able to carry a baby. So the body takes care of that and makes the menstrual cycle very irregular. When a person has this issue, they also have dependent edema. That means that if they're sitting in one position for too long with their legs dangling, or they're just sitting in a chair or sitting in a plane, that their feet are going to swell and their legs are going to swell. So we've talked about the way that the body mediates fractures. And so the osteoporosis can happen with adrenal system disorders as well. So glucose tolerance, you start to develop glucose intolerance, and you start to develop higher blood sugars within Cushing's. So the fat distribution also changes. It tends to cause a fat distribution specifically of the face, of the trunk, and it creates like a buffalo hump or a hunchback on the back of the neck. Also, the body hair tends to darken, and in women, they often will start to get dark facial hair as a result of the amount of cortisol. Petechia, broken capillaries, red cheeks, muscles start to atrophy. The hair starts to get very thin, and they end up with lots of stretch marks. This is kind of a picture for you to be able to visualize what's going on. They end up with lots of bruising. They end up with a round what we call a moon-shaped face. So whenever you see moon-shaped face, you need to be thinking about Cushing's, buffalo hump, key sign of Cushing's, truncal obesity, stretch marks, all very, very important indicators of Cushing's. Here's some other pictures of what this actually looks like. So we do have fat distribution on the back of the neck, the moon faces, and facial hair on women. And hair tends to get thinner. And then you can also see the striae or the stretch marks in that last picture to the right. So what kind of testing do we need to do? When we are looking at Cushing's, we need to monitor the blood cortisol levels, and we also need to do a 24-hour urine collection. This is going to be able to tell us exactly how much cortisol is being produced by the body within a 24-hour period. Or taking the medications, how much cortisol is the body being exposed to within a 24-hour period. So we also need to focus on the plasma adrenocorticotropic hormone levels. This is what is secreted by the pituitary and tells the adrenal cortex to make the cortisol. Also, cortisol can be measured in saliva, so that's often an effective way to figure out that a person does have Cushing's disease. When a patient has Cushing's disease, they tend to have low potassium and calcium levels. Their blood glucose level is higher. Again, they have higher gluconeogenesis and truncal obesity when exposed to higher cortisol levels in Cushing's. Sodium levels tend to be increased. That welcomes fluid retention as well. And lymphocytes tend to be decreased in this condition. So we've talked about provocation testing where we're trying to make something happen. And we've also talked about suppression testing where you're trying to stop something from happening. In Cushing's disease, you'll be doing dexamethasone suppression testing, and you're trying to figure out, is there a way that we can stop the cortisol from being released? And so with this, it's important that the patient try to reduce stress prior to the test and during the test, because again, stress causes the activation of cortisol, which creates a mess within the body. 24-hour urines. So the thing you need to remember about 24-hour urines is if it's in an outpatient setting, a 24-hour urine collection will be started at the beginning of the day, okay? So the patient goes in and pees for the first time after waking up. They do not include that in the 24-hour urine. Any urination, any pee that happens after that first pee, then will be peed into a hat, and the hat will be poured into a container that either needs to be put in the refrigerator for the time period of the testing or set on ice. And setting it on ice is most often what we do in the hospital environment. And you have to make sure that it's actively cold ice. It can't be sitting in room temperature water where the ice has melted. So in a hospital environment, the focus tends not to be on waiting till the next day. Whenever you get the container from the lab to start the 24-hour urine, then you automatically will just go ahead and start there, and the test will end 24 hours later. Now, if you're doing this test at home, remember you urinate before you start the test, first thing in the morning, then you collect urine for 24 hours. So what that means is the next morning when the patient gets up, their first pee will be included in the 24-hour urine. This helps to ensure that the concentrations aren't thrown off by having 2 early morning pees, because that is going to be more concentrated and can alter your test results. Here's an example of a container that a 24-hour urine is collected in. In the hospital environment, you just get a wash basin, fill it up with ice, and then you set the container into the ice. And you just refill the ice as it starts to melt away. But it's very important that it does remain on ice to give you accurate results. Diagnostic testing includes x-rays, MRIs, CAT scans. We're trying to figure out, is there a problem with the pituitary gland or with the lungs or with the GI tract that could be causing these types of symptoms. Radiological imaging will help you to know what exactly is going on with the adrenal gland. Patient-centered care. Since both of these alter aldosterone, which controls the salt intake, you have to watch for fluid volume overload. You need to do this by monitoring strict I's and O's and doing daily weights. Assess for signs of hypervolemia, having too much fluid on board. That'll be seen through pedal edema, distended neck veins, shortness of breath, crackles. Remember those sounds that sound like Rice Krispies? If there's too much fluid, you'll also have too high blood pressure. So your patient will have significant hypertension and tachycardia. The skin in patients that have Cushing's is very, very thin and fragile. I have seen tape literally pull off just whole sections of skin because their skin is so thick, so thin and weakened by the Cushing disease. So you need to change the patient's positioning every couple of hours to make sure they're not getting pressure sores, and then use non-adhesive methods to secure your IVs. Instead of using tape, use Curlex, or you can use gauze bandages, or you can use Coban. Coban's always great to secure IV sites. Other things, you need to take your medicines as prescribed. If you don't have enough cortisol that's being made, then you may have to take lifelong supplements. Your diet needs to be low calorie, low sodium, and low carbs. So as Cushing's syndrome, Cushing's disease progresses, you tend to have more motor weakness and more muscle problems. And you need to report a weight gain of over 2 pounds over a 24-hour period or 3 pounds over a week. And that is more than the body can put on in a regular time period like that. Again, dietary, we need to have low sodium, high potassium diets, and we're wanting low sodium, 2 grams or less, to help get rid of that aldosterone, get rid of that sodium, so we can get rid of the fluid of the body. Medications that can be used, you may see different antifungal agents like ketonazole that can be used, and that has a side effect where it alters the cortisol levels. We may also, in a patient that has Addison's disease, we may have to do hydrocortisone replacement therapy. So if they had Cushing's disease and it was an actual problem with the gland itself, they would surgically remove the gland. If the gland's not there, then it can't make cortisol, so you have to replace that cortisol in a pill form as hydrocortisone. So ketonazole, it's an antifungal agent, and ketonazole inhibits the steroid synthesis when it's taken in high doses. So important things to remember is that this is a temporary fix. As soon as I stop taking this medicine, my problems with cortisol will come back, and I do need to take this medicine with food. Mitotan, it causes selective killing of the adrenocortical cells. So things we need to watch out for is shock renal damage, and hepatotoxicity. So we're having problems with our kidneys, with our vascular system, and with our liver. Monitor for orthostatic hypotension, because what's happening is you're retaining fluid volume. As we remove the fluid volume, your blood pressure will drop. It can drop too low and become dangerous. Use caution when driving, and you may often have to take this for life. Hydrocortisone, this is what we use if you had Cushing's disease, something organically wrong with the gland. We take out the gland. We have to supplement hydrocortisone for life. So with hydrocortisone supplementation, if a patient is ill, has the flu, has a stomach bug, or is under stress, like they're having physical stress of the body, having surgery, or just emotional stress, the body requires additional steroids to be able to help the body function. And so the dose may have to change when the person is under stress. So different things we can do. We can use chemotherapy agents to help destroy part of the adrenal gland that's making the cortisol. Do a hypophysectomy. That's, remember, where we take out the pituitary gland, and we may take out the adrenal gland with an adrenalectomy. Okay, I'm going to start another presentation with this, and so I will see you over on that presentation.